Hello everyone and welcome to my channel. Today we're going to be discussing the management of hyponatremia, so stay tuned. The first thing we're going to do, we're going to define hyponatremia. And we can do this by thinking about symptoms, thinking about the serum levels, or thinking about the presentation. If we're thinking about the symptoms, we can classify them mild, moderate, and severe. If we're thinking about mild symptoms, we can think about lethargy, or we can think about irritability. If we're thinking about moderate symptoms, we can think about nausea, headache, confusion. Now, severe symptoms is something that we need to be looking for. Cardiorespiratory distress, vomiting can be early signs, somnolence, seizures, and a low GCS, less than 8. If we're thinking about serum levels, we need to remember the normal serum levels are between 135 and 145 millimoles per liter. If we're thinking about mild hyponatremia, we can think about anything between 135 and 130. If we're thinking about moderate hyponatremia, think about anything between 129 and 126. If we're thinking about severe hyponatremia, anything below 125. Presentations, we need to think about acute or chronic. We're going to use 48 hours as our cutoff. So always keep in mind, what's the presentation? Now, if we're looking at an acute, severe, symptomatic hyponatremia, this can be life-threatening. So this is time for us to call for help. Okay? Think, is it acute? Is it severe? Whether it's because of the symptoms, because of the serum levels. Now, before we start thinking about the cause, or thinking about management, let's call for help. Let's call ITU, let's call HTU, let's call a consultant, let's call someone senior. These patients should not be managed in the ward. They should be managed in a high dependency unit like ITU or HTU. The first thing we're going to do in the first hour, after calling for help obviously, we're going to do some general investigations, any baseline investigations. Once help has arrived, we're going to prescribe 150 ml of 2.7 hypertonic saline or 3%. It really depends on the trust, so always check your trust policy. We're going to do this over 20 minutes and then we're going to check sodium. Our aim is going to be a raise of 5 millimoles per liter of sodium levels. If that's accomplished, then we try to maintain this at about 8 millimoles per liter over 24 hours. But if we fail to do this, we can try one more time. We need to remember that we need to keep the raise to 8 millimoles per liter in 24 hours. If we do more than that, then we can cause some serious issues because the body is not used to it. So let's ask some questions. Are symptoms resolving? Is the level target reached? And is this real hyponatremia or pseudo hyponatremia? Now, pseudo hyponatremia, there's a couple things you need to be thinking of. One is hypersmolar hyperglycemic state, quite common. Usually we'll have a high osmolality. You can also think about mannitol, hyperlipidemia. Now we know diuretics can cause sodium loss. Transurethral, and if the kidneys are not functioning properly, reception of the prostate, they can cause or an artifact from the lab. So we need to think about all of these usually have yes or no. Normal osmolality. But what is the answer? Is no. We're going to think about osmolality, hyperbolemic refers to the concentration of solutes
or eubolemic
in a solution.
hyponatremia. We'll
The
talk
higher
about
the
course
concentration of solutes, the higher the
later. The answer is
osmolality.
yes. Then
And so
we need to
on.
think about diuretics and renal.
Now, usually,
Or
hyponatremia, real hyponatremia, will have low osmolality. The next step is we're going to check the urine osmolality. We're going to check the levels and see whether the osmolality of the urine is less than 100 millimoles per kg or more than 100 millimoles per kg. Remember that the serum osmolality is different than the urine osmolality. Serum osmolality is usually between 280 and 290. If we're thinking it's less than 100 milliosmoles per kg, our first differentials are going to be primary polydipsia, low solutes, and beer hypotomania. If it's above 100 milliosmoles per kg, we need to do urine sodium concentrations.
now if it's above 30 millimoles per liter, we're going to ask ourselves two questions. Is this patient on diuretics? Or is this patient having kidney disease? If the levels are less than 30 millimoles per liter, then we're going to think about a couple of things. First of all, we need to ask ourselves if there is low effective arterial volume. So is the fluid status of the patient? Is the patient dry? If that's the case, or not, but we're still going to think about hyperbolemic hyponatremia or hypobolemic hyponatremia. Now if we're thinking about hyperbolemic hyponatremia, now think about cardiac heart failure, cirrhosis, and nephrotic syndrome. All these patients are going to have edema. So basically, because the kidneys are normal, they're working properly, they're going to reabsorb sodium, so the sodium concentration of urine is going to be low. However, because there is low volume because of the third space, because of the edema, so low circulating volume, this is going to cause ADH to be released, increasing the retention of water. Same thing for cirrhosis and nephrotic because of the low albumin. Moving on, hypobolemic hyponatremia. We're going to think also about chronic kidney disease and hypothyroidism. Usually, when we have these two conditions, we expect to find the sodium concentration in urine to be high. Now, in chronic kidney disease, there's going to be an increased release of renin. So this will put the RAS system into function, increasing the production of ADH and aldosterone, causing water retention and some electrolyte retention, causing increased volume. Now if we're thinking about hypobolemic hyponatremia, we're going to think about conditions that are going to make us lose a lot of volume, like diuretics, vomiting, diarrhea, hypoaldosteronism. Basically, there's an increased volume output or urine output. So even if the kidneys are actually normal, the urine concentration of sodium is going to be high. Now, diuretics usually cause depletion of sodium and chloride. Vomiting is going to make us lose acids, causing alkalemia in the blood. So kidneys will have to lose bicarbonate. This will cause low sodium. Diarrhea, on the other hand, will make us lose bicarbonate, causing acidemia in blood. So if we're thinking about general management of hyponatraemia, hypoaldosteronism, and we're thinking about the underlying cause, there's going to be a decreased sodium and potassium upon treating it. There's not going to be treating any aldosterone being secreted, but there is the sodium channels are going to be low. And we're going to have related to hyperbolemia, eubulimia, or hypovolemia. If we're thinking about hyperbolemia, we're going to try some fluid restriction. Now, if we're thinking about all the causes of hypovolemic hyponatremia, like when you have all vomiting and diarrhea, we think about fluid replacement, sweating, and if we're thinking about pancreatitis, we think about SIADH, because of the third space, endocrinologist. It's going to be low volume circulating. The kidneys are usually going to be normal. So the urine sodium concentrations are going to be low because there's going to be some reabsorption. Now, if we're thinking about eubolemic hyponatremia, we're thinking about SIADH, or we're thinking about beer hypotomania. SADH can be associated to lung cancer and other conditions. There is basically an ectopic production of ADH increasing bile retention. This is going to cause dilutional hyponatremia. And that's it for today. Hope you enjoy it, and I'll see you again in another lecture with Dr. Luke. So we're thinking about what we're aiming for. We're going to check the serum levels every 6 to 8 hours. If the sodium levels are less than 6 millimoles, or the sodium levels are more than 6 millimoles. If they are more than 6 millimoles, we need to be careful about this. Think about danger. There is a chance this could be leading to central pontine demyelination. If that's the case, we need to let the patient have water 1 liter over 30 minutes to check sodium levels again in 2 hours. If the sodium levels after 6 to 8 hours are less than 6 millimoles, we'll check again in 12 hours. If they're more than 8 after 12 hours, it's going to be danger for central pontine demyelination. If they're more than 12, 24 hours, same story.